So, dear Professor Kata, dear colleagues, thank you so much for this opportunity to start a second AI webinar under ACNS leadership. And thank you so much, Professor Kata, for this nice opportunity. I just want to say a few words. So today we have a second webinar covering two topics. A broader one is ethics in neurosurgery, and a more specific one is the application of augmented reality. So I'd like to remind you that AI refers to an entire field of computer science dedicated to develop technologies that, to a certain extent, mimic human behavior, human cognitive functions. And in fact, there are many such technologies, and not only machine learning, but machine learning is cornerstone, of course, but there are other technologies in linguistics, in physics, in psychology, in computer sciences, and so on and so on. So augmented reality is very close very closely related to these technologies today. And today we have two speakers, Dr. Mohammed Helmy, he will deliver his lecture on ethics, and Dr. Anton Konovalov, he will talk about augmented reality, and we'll also have two discussants. Dr. 𝑉𝒂𝒂𝒂𝒂𝒂𝒂, who's a neurosurgeon and an expert in artificial intelligence, research and application. Nowadays, he conducts a very nice research to study how neurosurgeons and other neurospecialists perceive synthetic medical images. Would be very glad if ACNS community can take the advantage of this research and can participate in this research, but we can talk about that later. And Dr. Fedor Gravenev, who is a neurosurgeon, a PhD student, and his PhD study is related to machine learning and using ML models in predictive analytics to predict risks of unruptured aneurysm surgery. So, Professor Kato, if you can open this webinar, we would be very happy. Thank you.
Yes, thanks so much. It's a very nice introduction, Gleb, as always. And I think I'm not not as so familiar with the AI, but I think in 5-10 days, in neurosurgery, surgical field is almost covered by AI or robotics or very new techniques, I think. So everybody should know what you are talking from now. So we are very much expecting your lectures. Thank you very much. Unmute, please.
Yes, and the first lecture is Dr. Mohammed Helmy. So, Dr. Helmy, would you share your screen, please?
Okay, thank you. Screen. Okay, so can you see the full screen now, right?
No, we see the slide mode, and we cannot see a full screen. But you can open your presentation on the full screen. Then you can share your screen and select the full screen mode as a separate window.
It's full screen here. I don't know if you can see it or not.
No, we see only slide mode, separate slides. Yeah.
How about now?
No, well, we don't see the full screen mode. Would you open?
There's where you were before, it should show on primary, and then I think maybe you have to change it to show on secondary monitor. Maybe it sees the Zoom as a secondary monitor.
Okay, please wait a second. I'll try because this is a different.
You can select a separate window.
Yeah. Just please. So how about now?
Oh, it's perfect. Thank you.
Okay. Yes, so So good evening, good afternoon, good morning, everyone. So I'm very glad to talk with you today about the ethical consideration of AI, artificial intelligence, in the future of neurosurgery. I'm Mohammed Helmi, a neurosurgeon based in Shanghai. And I think this topic is not just fascinating, but it's very fundamental to the future of our career. So actually, when I talk about the future of neurosurgery, of utilizing AI in the future of neurosurgery, I think the word future is a little bit misleading because AI is already here. It's no longer a futuristic concept. It's influencing how we diagnose, plan, operate, and even follow up with our patients in daily basis. AI is a power, but with power come responsibilities. So let's go for a brief history of AI in medicine and neurosurgery. Actually, AI in medicine began decades ago. It started in 1970, when scientists from Stanford University introduced the MySyn, which is expert software. And this based the expert system. And this system helped us to do some prediction model or help us in diagnosis in patients with blood infections. Actually, in that time, even in 1970s, which is very early in using AI in medicine, it helped us to, it gave us more competitive results than the general practitioner in that time. However, in neurosurgery, it also started in last decades, 2 decades, with image processing, segmentation, planning for stereotactic radiosurgeries, analyzing some MRIs images. And now we start to have a new era of using artificial intelligence in neurosurgery with the help of machine learning and deep learning, which take this further for like doing some automatic hemorrhagic detection, outcome prediction models, robotic assistance, and so on. So with current application, we use this in imaging. We can use it in intraoperative navigations and robotic assistance. For example, the microscope or microscope modules like the Flow 800 and so on. It also have some prognostic modeling in traumatic brain injuries, stroke, and glioma. It also helps us in the field of functional neurosurgery, where it can give us more functional mapping for patients with lesions in very important areas. It also can give us early prediction of complications like vasospasm or hyperperfusion syndrome. So it has a very wide application in neurosurgery. But with this power, there is a promise and problems. The promise, it gives us a high precision rate, a more personalization treatment, a higher predictive power. But it also has some problems like algorithmic opacity. We don't know who trained the algorithm or in which, based on what, and and which biases comes with this algorithm training. It also have some issues with data privacy. We know that all AI models, they are trained on very big data sets, but we don't know whether these data sets are homogeneous or heterogeneous. Like they use these data sets from only one population, so there is no presented population, or it is a global data learning. It also inherits some biases, and it also gives some dependency risks. For example, if I use AI-related AI-based modalities, for example, like Flow 800 in microscope, and it shows me, for example, that this patient probably the bypass is safe in this patient, but after the bypass, the patient develops some hyperperfusion syndrome. So who is responsible for this? Is it the AI company or the physician who trusted this, or the hospital, the institution that agreed to use these modalities? So in my opinion, the surgeon AI relationship should be used as assisting tool. It should not be an authority. It should be the knife in the surgeon hand, and it shouldn't be the one who holding this knife. It also needs to augment our insight, not replacing our judgment. And we should have a very critical evaluation for all the output of AI used machines. Finally, we have to have we should be the decision makers, not the AI. So the key ethical challenges using AI in the neurosurgery, first, the bias and inequality. As I said, that there is a training, we train the data, but we don't know the training data, whether or not it lacks diversity, whether or not the data that are trained on North American population can be used to help us or diagnose or assist our diagnosis in patient in Asia. It also could lack the transparency issues, whether it is just black box style, or it is based on more sophisticated decision making. We don't know who is accountable if there is any problem happens with the using of the AI. Who is responsible for this? The vendor or the hospital that use it? As I said, the data privacy still a big issue. The patient consent. If I told the patient, based on the let's say any preoperative AI-based machine, I suggest this patient to have this kind of personalized treatment. The patient doesn't know how I make this decision, or how even the AI machine makes this decision. So if the patient have, we call it literacy, AI literacy. If the patient has AI literacy on this, so whether or not the consent that I take him is valid. So it also have some depersonalization issues. Patient becoming more mere to the data points. So as I said, it's a black box system. I think there should be some ethical frameworks. It should be human-centric. So the human should be the core of in AI development, because each decision that is made by this AI tool, it will affect a patient life. It should be evidence-based. So we have to have a very strong validation before we implement the using of AI machines in our institutions. It should be very transparent. We need to know why this AI machine makes such decision, and it should be regulated with clear governance. So, and of course, it has to have some flexibility for innovation. So, in this point, I really hope, like for some organization like WFNS or ACNS, it has some ethical committee that is responsible on governing these kind of AI companies before they give any products or AI-based products to the clinical institution to use. But when I look ahead, I think it's very promising, because just imagine if we have real-time AI feedback. If I want to do a STMC bypass surgery for a patient with myomed disease, and just seeing through the microscope lens, the microscope lens can measure all the hemodynamic parameters of this patient recipient vessels, and it will tell me which recipient vessels is more adequate to doing this bypass. It also could be a very good interoperative predictive modeling. For example, if I have aneurysm and I do some temporary clipping for the parent artery, it could show me when this patient will have some distal ischemia. So it will give me some predictive values. And I think the AI-enhanced neurorehabilitation will be a very big advanced, it will be more advanced in the future. It will be like the massage chair, where it will give you a very personalized rehab plan for the patient. And I also can see that there will be one day with nanorobotic AI-assisted AVM embolization in the future, where you have a very difficult, complex case of AVM where you cannot go by the conventional microcatheter or micro wire. So for these patients, I think using AI is a must, but with AI comes so many responsibilities. My final thoughts, I think we all have challenges. AI will never replace us. I think it will assist us, but it will not replace us. What will replace us are the surgeons who know AI better than the people who don't. These are the risks. It's not the AI. I think the ethics should guide the technological integration. I hope that there is some organization will be responsible for the ethical part. And I think if in the future, if we have this kind of AI revolution in medicine, I think it should be in each department, there should be ethical committee, the same as for the research, but this one for using AI tools in the hospital. And we always need to know that humans are responsible, whether in the operation room you use AI or human being. We have to be accountable for everything that happened because this gonna affect the patient lives. So my talk today is very quick and concise, but I think AI is a great power, but with a great power comes great responsibility, and we need to be more focused with ethical using of the AI in the future. Thank you so much.
Thank you so much, Dr. Helmy. Thank you for sharing your wisdom on such an important issue as ethics in neuroscience with the AI technologies. And now we have some time for discussion. So, Dr. Stathis, would you kindly express your opinion and maybe ask questions if you have? So please.
Yes, thank you, Dr. Tandilov. Well, Dr. Helmy, very nice presentation. Thank you. I particularly liked the statement you made about that AI should be a knife and not the surgeon, so it should be the knife. One of the tools in our toolbox, like our expertise, right? Like our experience. If we, for example, make prediction models, it should just be one of the objective second opinions. I like to call these prediction models like objective second opinions. And you have to do with them. The patient has to do with them like they do with other second opinions. They can take it seriously or not, and that's why also AI literacy is important. And that's what I wanted to talk to you about AI literacy, because one big problem is not only the responsibility when using AI models that are already developed in the clinic, as you said, but also when developing them, and when in part of the development, I guess, is publishing and research on AI. And I see that there's a big problem because a lot of these AI studies are submitted to neurosurgical journals, but there really is a lack of reviewers and editors able to assess them. And it goes even deeper, this problem. Then, okay, maybe such a paper gets through review and maybe it's quite good and it gets published. But, like in the New England Journal, also a lot of randomized studies get published and not all of them are great. And you have to interpret them with some care if they can be applied, as you said, to your own patients or not. And that's the big step, that through webinars like this, we have to increase the literacy of our colleagues, of our clinicians, and of the patients to be able to see, is this published thing that looks, of course, everything that published looks great, if it's really safe to use, if it's really useful to use. So what do you think about the challenges in also training reviewers and your colleagues in AI literacy?
Yes, so AI literacy actually is one of the biggest problems that I think it needs to be discussed. So I think the most important thing, as we say, that if we have such a ethical committee in each institution that will take responsibility of teaching the physician. For example, if I need to incorporate so many fascinating AI systems in my hospital, I should have this kind of ethical committee that is responsible for teaching not only the physicians, but even the patient. Like, if I use this kind of AI models and it gives me this result, I need to tell both the physician and the patient why and how it gives me this result. And I have to be very knowledgeable about the output of these information of AI machines. So I think having such kind of committees or ethical committee in each department is a big tool.
And also, do you, at your department, for example, do regularly like educational sessions for residents or something on AI or something like that? I think those would be really important. Like journal clubs, we do a lot of journal clubs always, of course, in every department around the world. We talk about, we are very excellent as doctors, even in medical school, we learn how to analyze randomized trials, and if this really was a good one or not. But we're really very poor still at, so even in medical school, it should actually be part of it. I don't know do you know if it's part in your university for the medical school curriculum? AI?
Yeah, it is. Yes, we have we have these courses, but actually it talks more about, it's a general courses about ethics in medicine. But I mean, using AI as a tool nowadays, it will not be uh, as in the past. I think it will be more sophisticated. It will be in each field or in each part of the patient hospitalization period, from pre-operative to intraoperative to post-operative to care and physical therapy. So what we learn and what we know about the ethics in medicine, it will not be enough in the future of AI in medicine, I think.
Absolutely. It's sneaking in everywhere. Yes.
Yes.
Thank you so much, Dr. Stajis. Thank you so much, Dr. Helmy, for very nice discussion. And actually, the mission of our ACNS AI subcommittee is to increase AI literacy. So I hope that this webinar serves that goal today. And if we don't have any questions, because I can see.
Dr. Danilov, may I ask you a few questions too? Thanks. Dr. Helmy, thank you for your engaging lecture. Indeed, artificial intelligence is rapidly developing technology, and it's been increasingly integrated in the various aspects of our lives. However, we must exercise caution when we implementing artificial intelligence in medicine and in neurosurgery particularly. You has highlighted a very crucial topic that cannot be overlooked, and I have a few questions to you in this subject. First of all, we all know that artificial intelligence can be implemented in all the ways of healthcare: screening, diagnostic, decision-making, treatment, and so on. But how do you think? Are there any scenarios or situations in neurosurgery where artificial intelligence might be inappropriate or require some additive oversight, How do you think?
Okay, so this is a good question. Thank you for this. Okay, I sometimes I use this example to discuss the dangerous aspect of AI. Okay, so now if we talk about the brain-computer interfaces, we can know that in so many institutions, they are trying to use it now for the patient with the movement disorders. And some people, they invent some modules that you can implemental BCIs, the brain-computer interfaces, and this one can take or decode the patient, how to say, thinking, and it can show you on the screen. This is a very good thing, right? If someone cannot talk and suddenly you can know what he's thinking of, it's very good. But if you think about doing some reverse engineering things, where you can not only decoding, but just implementing certain kind of thoughts to this people, to this certain population. This is also a very dangerous one. But who can control this? I don't know my data, the data that is taken for the patient, where it is stored, who can control them, if there is any data breach, I don't know. But at the same time, if the same company or other bad people who could hack these brain-computer interfaces and get into them, and rather than just decoding the information, it can input more information to that patient, let him have another thoughts or bad thoughts, right? So it could happen. This is not how to say, a science fiction thing. It could happen, but how can we control this? Who is the one who gonna govern these kind of technology? Yeah, so this is one of my concerns.
Okay, thank you a lot. Totally agree with you. And my final question, you told a little about the informed consent for the patients for using their data. Well, as I said before, artificial intelligence can be utilized in all the ways of healthcare process. Do we have to inform patient about all the situations when we use artificial intelligence, on your opinion, or we only have to tell them about artificial intelligence when it utilizes in treatment modalities, and do not tell them about the diagnostic? What do you think about this?
I always think the patient should know what he should know, right? So in this part, I don't need to tell him how the machine learning works. I just need to tell him why this AI machine gave me this kind of, how to say, recommendation to do this operation in this certain way. For example, if I have if I have a machine that can see all the hemodynamic parameters in patient blood vessels, and before I do the operation, I can make a keyhole craniotomy just over the blood vessels that the machine recommended to me, right? So in this part, I need to tell the patient why I need to do the craniotomy here, not in that side. The patient, I think the patient must know this. Why it is this artery, not that artery. Why it is this recipient, not the other one. So if the patient doesn't know why this machine gives me this kind of recommendation, and based on this, I made my decision, I think it's unethical. I think in this scenarios, we need to tell the patient why we need to do this kind of procedures, right? But I don't need to tell the patient how the machine calculate this, right? So yeah, the patient needs to know what he should know.
Thank you a lot.
Thank you, Dr. Greven, and thank you, Dr. Helmy, for such a fruitful and valuable discussion. Now it's time to give the floor to our second speaker, Dr. Anton Konovalov. Dr. Konovalov, please, the floor is yours.
Yeah, thank you so much. Just give me a few seconds to start the presentation.
Take your time.
Is it working right?
No, yeah, we see the full screen. Thank you.
Yeah. So first of all, I would like to say a few words about great thank you for everyone who gave me this opportunity to take the part in this meeting. Especially, I want to say thank for Professor Kato for all her kindness, hospitality, expertise, which she shared with me and hundreds of, even thousands of neurosurgeons over the world. So that's a great honor to me to be here today. And my topic is about using the augmented reality, which is new tool for neurosurgeons and other medical specialists, which getting more and more popularity nowadays. And firstly, I would disclose some things. My name is Anton Konovalov. I'm from Burdenko Neurosurgical Center. I'm a neurosurgeon and a researcher in this great center. We did the grant by Russian Science Foundation. And this work, which I would share with you today, would be not possible without help of two companies, which is Magital, this company from St. Petersburg, who did the software for our AR navigational system, and especially for Inabitec DICOM viewer, which helps us to segment all the models. Let's discuss our technology. I would say that the stylistics of my presentation is not accidentally done with such a cyberpunk style. I think the youth generation recognized this style. I would like to perform my presentation in the such entertainment way, because our job is take the part of the great part of our lives, and we should get the pleasure from day by day of our practice. And the technology of augmented reality nowadays is possible by such a device which can enhance and give us the information from DICOM viewers and put the neurosurgeon in situation when he can align the augmented reality segmented models on the real patient in the operating room. So we use the segmentation, and all our surgical team, the old surgical team, use the preoperative 3D planning for all the surgeries. So we do not perform surgeries without preparation. And the preparation takes the 3D planning of CT, MRI, DSA, and so on. So we can implement all the information from these studies and use this to perform the individualized anatomical strategy and surgery for each patient. Especially, we can segment any structures and make the 3D models from them. That's why we use this special software for this. I think all of us have seen a lot of such 3D models which showed by different neurosurgeons all over the world. And the main idea that we don't use the 3D atlases, we use the exact patient anatomy for all the surgeries. For special patient, the special 3D individualized anatomy. And then the next step which we developed, we tried to implement these 3D models and individualized anatomy by augmented reality intraoperative room. So I would say that nowadays augmented reality is the option which helps us make a step forward from 2D screen DICOM data analyzing into the intuitive, really useful tool, and perform the 3D modeling and DICOM analysis on the patient itself in the operative room. So we use the Microsoft HoloLens, the second edition device with the Magital company software. And one of the main problem is the model alignment. So we use the 3D models, but we should exactly position them on the patient in the operative room. For performing this alignment, we use this. I showed our AR station, which is on some trolley, which we can get into all operational rooms in our center and quickly perform the AR navigation. So here we have the laptop with the Wi-Fi module, and you can see the QR code, which helps us to position the model and to lock the model with the QR code. And when we change the positioning of the patients, we can change the position of the QR code, and the model will slide after the patient, and we will have the saved positioning of the model. Here are the example how we can perform the surgery with the Microsoft HoloLens. So the surgeon should wear this device, and it can enhance some information during some steps of surgical procedure. But I would say that it's not the tool for performing the surgery, but it's the main tool for performing the pre-operative planning. And here you can see how we positioned the QR code before. So we developed the 3 different ways to use the model alignment in a surgical room. And this is the one of them. It's a QR code which put on the patient with a special 3D frame. Then we performed the CT scan with this 3D frame, and then fused the information of the CT scan with the frame with the MRI and other segmented models. And this is how it looks from the view by Microsoft HoloLens. Here is the second type, which we use to align the model. When we just by knowing the craniometric points, you can see the spheres, the white spheres, which we put on the exact craniometric points like the Nasion, Bregma, Stephanian, and others. And when we align these spheres on the exact patient's craniometric points, we align the whole model. And the last one, the third method to align, is kind of really familiar for us. We use the same by optical neuronavigational systems, which we put the reference points on the patient head, and then we can align the model by these points. Here you can see how we perform these points with the special tool, and we need to wait for a few seconds to put the sphere on the place, and then we can align the model after, right here. And when we use this augmented reality model on the patient. By our science interest, we, of course, evaluated each method, and we have some different types of accuracy and time requiring for all the alignment. And the most accurate method is the second one, with which we use the 3D personalized QR code frame and perform the CT scan with this frame before the surgery. This is the most accurate type of alignment. But it takes some preparational time to perform the CT with the patient, to prepare the whole model before, but it's quicker in the surgical room, so it takes less time than others. The other, the second most accurate type is the third one, when we put the special neuronavigational points with the tool. And the least accurate is when we put the model just by craniometric points. But the putting the craniometric points, it's a quicker way, And we can use this in procedures when we don't need really such accurate data. So I will show when. Here is how we can perform the pre-operative planning before the surgery, like in the doctor's office. You can segment all the data from the MRI, angiography. You can paint all the structures. Here you can see the arteriovenous malformation. We segmented the nidus of the AVM. We segmented the afferental vessels, the draining veins. We can evaluate the whole model and the individual anatomy before the surgery of the exact patient, and create the special strategy for this patient. The size of craniotomy, the dangerous fields, and other things. Here is the example of the functional zones planning for such disease as developmental malformation is the focal cortical dysplasia, and it was located in pre-central gyrus, and you can create the whole brain map with all the gyrus and sulci and align on the patient, and even you can navigate the craniotomy and so on, but you can understand and realize what's the angle of the surgical attack you should you should try, which may be dangerous field, which you should do not to perform, and so on. So it's kind of more intuitive way to plan the surgery. I really do like to perform the AR marking to find the subcutaneous vessels as the STA before the bypass. It's really useful. For example, you can plan the incision. Some surgeons who perform the STA bypass may experience the necrotizing of the flap after the surgery. When we incise the flap, not in according to the blood supply and so on. So it may reduce the risk of the skin necrotic complications, and you can just by few seconds realize where's your path of surgical dissection. And it's really useful for this special surgery. You can mark the STA branches, you can mark the whole incision, you can mark even the recipients of your bypass, and evaluate how far you should go with the craniotomy. Because sometimes your recipient can be located far behind the classical pterional approach. And here you can see the incision marking before dissecting the STA branch. We tried to create the 3D models of the tracts, and here you can see the pyramid tracts of left hemisphere and the green model of the tumor of central region. And it's not the game changer thing, but it's a useful option to understand from which projection and angle you can meet the critical structures. And I think it can be useful for some special surgeries. Few examples how we can use it for just a simple aneurysm. You can see the green model of the aneurysm, the location of the bifurcational MCA aneurysm. It's the small size aneurysm, but this patient has the huge frontal sinus, And sometimes it's a problem to predict where is the frontal sinus edge could be, and not to open this frontal sinus to prevent the CSF leak in post-operative period. So we can use this technology to for this purpose. And even more, we can use the AR navigation for AVM. This is one of the examples how we can use it. So for complex anatomy of AVMs, the big ones, we can use to create these 3D models of all the parts of the AVM. Even we can divide the AVM for different parts, like for basins, which supplied by some ACA, MCA basins, and so on. And it's really nice to see all the AVM anatomy structures before the surgery and realize how far you should go for afferental vessels before the surgery, which projections which should be, where can I meet them, like right behind the draining vein, which is really often for some afferential vessels. And I think it's kind of useful tool. Even we can navigate some procedures such as the EVDs and intraoperatively, even intraoperatively. So you can see the example how we put the EVD with the 3D AR navigation, the patient with the subarachnoid hemorrhage and acute period of hemorrhage and aneurysm surgery. Few words about the spinal neurosurgery. It's a promised tool to reduce the X-ray for the surgeons and other people in the OR room. So some procedures we can plan or perform with the augmented reality for spinal surgery without X-ray. So we can use the augmented reality navigation for like some simple spinal surgeries. I'm not the spinal surgery, but our spinal surgery surgeons try to implement this in some pain surgery things to navigate the needle for foraminal blockaging and so on. So it's we try to evaluate right now these options, and I think we will publish some papers in the recent future. Even one more thing, we can perform some proctoring by using the AR goggles, and your supervisor can see all the things you perform as a young neurosurgeon in the OR room and can control and suggest something during your surgical manipulations. If he not really close to you, like if he far from your surgery room, or you need some expertise in field which your surgical team could not have at the moment, or some extreme urgent purposes, it's a promising tool as well for this purpose. And I will show for like just addition. This is the mixed reality, which we can use for some imitational procedures for training, like for EVD placement. This is the other goggles, which is MetaQuest 3, and we use different software, free software, to perform the training procedures, such as the EVD or lumbar puncture or something other surgeries. And you can train to perform some surgery which is in the virtual or mixed reality in the individual anatomy of the patient. So if, for example, if you need to perform something like in 1 hour, some surgery, for example, EVD placement, and you have narrow ventricles, you can try like for 100 times to put this EVD in the virtual reality before you will perform the real procedure. And it will help you to get the special individualized trajectory for this patient. And then you just come into, for example, emergency department and perform the EVD insertion like you did this like 1,000 times before for this person, patient. And we try to perform some surgeries before the real surgeries. For example, the AVM resection or clipping the aneurysm before the real surgery. Like we try to get the proper type of the clip before the aneurysm surgery, the trajectory of the clip, the type of clipping by clips. And when you perform this planning before the real surgery, you have the 2, even 3, or even more scenarios in your head before you go to the real surgery. And you know, like, if the plan A will not work, I have like 3 more scenarios how I will solve this problem in the OR, and you just get prepared for the surgery. So I remember how the Japanese surgeon like training before the real surgery, they teach me that you should perform this surgery 1,000 times in your head, and using the mixed reality helps us to performing the surgery not only in our mind, but use some tools in virtual reality to make it more realistic. And here is some just different surgeons in our institution which implement the AR in the different procedures. We use this AR navigation and develop it more than 2 years. And we performed about 120 surgeries, different type of surgeries. And of course, I would say about the pros and cons of this tool, because nothing can be super without any disadvantages. And of course, pros of this system and tool is that it probably has perspective to some X-ray vision. It's not the exactly X-ray vision, but you get something. You get the tool which can surrogate the X-ray vision for you. This helps. This helps to make some accuracy in your surgery. So it shows you the location, the size, the trajectory of the pathology, and you get more accurate for this. This is the type of navigation. I would not say that this is the killer of the optical navigation. Of course not. This is the mistake. The optical navigation is the classical tool which we should use all the time, which we need. But this is the additional option for navigation, which we can use with optical navigation. It helps us for neurovisualization of different 3D individual pathologies, and it helps us to perform the intuitive planning. The disadvantage of this option, of this methodology, is that you need to have the special hardware as the Microsoft HoloLens goggles, the computers, the software. You should know the 3D modeling skills. You should know how to segment, how to create the models for AR, how to put them, how to align the models, and so on. It takes time to get skilled in this field. And of course, this is not the most accurate tool in the world. So we developed and we try to make it more accurate. in alignment model for real object, but it takes more and more research to increase the accuracy of this tool. I would say thank again for all the team, for all the doctors which take the part in our meeting today. And if you have any questions, I would be really happy to answer them. Thank you so much.
Thank you so much, Dr. Konovalov. Every time I see these beautiful computer-assisted images, futuristic images, I think the future is already here. Thank you. So now it's time to discuss your talk, and let's ask Dr. Statras to start.
Thank you, Dr. Konovalov. That was really motivating and modern, as you already said, take on presenting something. So great that you can make it also fun and interesting with the cyberpunk stuff, and making it also look a little bit like a gamification of surgery, you know, which is for our generation probably very good. And when I have not thought so much about AR, but when you really showed the very practical applications, I really thought like, wow, this is compared to AI, this is like a no loss, almost no drawback situation, because in AI, you know, the models don't always work, and there's a lot of uncertainty and ethical blah blah around it. But for AR, it's basically using the imaging data that we have anyway and showing it in a way that we can extract with our brains much more information from it. So it's really a no loss situation, and I really like that you showed a lot of practical applications. I wanted to ask you especially about the alignment, because the couple stuff that I've seen with AR and I've tried, there were always two difficulties, which in your system doesn't seem to have. It looked very nice. The first one was to make really useful models. So the first question would be, how long does it take you to make these beautiful models where you have the brain, like for example, for the AVM and all the vessels? Like if you said it takes time to get experience, but once you are experienced, how long would you say it takes? 20 minutes or 2 hours? And the second thing is, you showed a lot of the co-registration, which usually is the problem, right? A lot of the systems that I've seen, they have very nice images, but it's like here next to the head and not on the head. So especially for the spine, I was wondering, I saw these fiducials and you said you can do it without x-rays. So how did that work?
Yeah, thank you so much for your questions. The first question about how much time it takes. In the experienced hands, it would take in average like 10 to 15 minutes. And it depends on the complexity of the model. So you write about the AVM models, they are really complex, and it depends what I should, what I wanna see during the AR navigation during the surgery as a neurosurgeon. So should I colored all the feeding vessels, draining vessels, or should I have some like functional zones as the separated 3D models and so on, like ventricles, maybe tracts, and so on. So, and with the increasing the complexity of the model, we increasing the time requiring the model creation. And I would say for the most complex model, I would spend in a half of an hour. Like I do perform the planning for all the AVM surgery. So this is the regular job for me, just to sitting in my room and performing the 3D planning and segmentation for every case I do in the vascular neurosurgery. And it's just a few more time to put this 3D model from the computer into the AR goggles. That's it. So the model creation and alignment, let's say it will take like 10 to 15 minutes, and it depends on the protocol of alignment which we use. So I told that we did some research of comparing different types of alignment, and nowadays the most frequent type is when we use the tool for putting the points, like in regular neuronavigational system. And you just have the whole model in your computer, and then you try, then you spend time just to align the model, and that's it. And the second question about the can you just remember the exact question you asked?
I also have to remember what it was exactly about. So at the time,
I
and
remember.
then the spinal spinal alignment with
Yeah.
these fiducials I asked about, because for cranial it's quite clear, but for spine the landmarks there's not really good landmarks on the skin, so usually it's very difficult. So I wanted to know how you do that.
Yeah, exactly. Yes, the spinal neurosurgery and the AR application is the really hard field for us. I would say that there are a few main things we should do every surgery. Like we should position the patient in the real surgical position when we perform all the CT scan. Like for our cases, we use the intraoperative CT scan. We put the fiducials on the patient, which is already positioned in the surgical positioning. So we cannot perform the preoperative examination, CT scan, and MRI when the patient lies on the spine, because the alignment will be like in the other room for a patient. The mistake will be so big, and alignment will be not useful. The second one, we should put the fiducials and register the fiducials after the CT scan. And then after these few steps, few rules which we performed, we can use the AR navigation. So we will see the most accurate for our day's model alignment by using the intraoperative CT scan and the AR goggles. So right now we are in researching the right protocol for AR navigation in spinal surgery.
Very nice. Okay, so you make a scan with the small fiducials, and then so that's a very nice way to do it in a kind of low materials setting. I mean, you do have to have the CT, of course, but that moves me a little bit into the last question I wanted to ask, which was about the advantage of AR versus a neural navigation system, because theoretically you could do a lot of the stuff also with the neural navigation system in terms, I mean, you cannot show as nicely. You can do everything, I guess, but it's more complicated with the neural navigation system. Maybe it's a bit more precise, but my point was, isn't the advantage of the AR approach also that, for example, in these neural navigation systems, they're basically only two companies, and they are gatekeeping, and it is very expensive, and they break, and you have to call them. But the advantage of the AR could also be that, okay, you have to buy this HoloLens and maybe a computer, but theoretically this could be like something also for global neurosurgery, right? To make it everywhere, even if you don't have this big workstation, to be able to use very accurate navigation. So also in your project, are you like working towards that kind of application for global neurosurgery?
Yeah, as I said before, we cannot compare like the optical neural navigation systems with AR, because it's fundamentally different types of physics. So this is the different types of methods, of tools, and I would like to say that this is options which can add something to each other, and this is the great mistake to conquer the two methods and try to say that optical navigation better than AR, or AR better than optical navigation. I think this is not right, and probably the Brain Lab neuronavigational system, which implement the AR in their newest model of optical navigation, and this is I think the proper way to develop both methods together and get the exact advantages from each one. I think that's the answer for your question.
I absolutely agree. My point was more that if you have no navigation at all and you want to use some visualization, then probably if you have nothing at all, it's probably easier to get started with an AR system than with a neural navigation system. I would argue. I would imagine that, but
it's really hard to say that, because it's easier to get the optical neural navigation than the AR right now. So we don't have such markets which can give us the end product as the AR navigation. So it's kind of the scientifically developed products, the startups, and really few teams do this in their research right now. On the other hand, every neurosurgical department has the optical navigation, and as a young neurosurgeon, you get acquainted with optical navigation first, than with the AR. So that's why kind of the AR, the more advanced step for navigation than the regular method.
Yeah, right. Thank you so much for a very nice lecture.
Thank you.
Thank you, Dr. Stathis. Thank you, Dr. Konovalov. Lots of questions, but probably the see all the answers in future. Now we should give a word to second discussant, Dr. Fedor Grebenev, and then we have one question from Dr. Thi-Hwan Hua. So, Dr. Grebenev, please, would you please share your opinion?
Dr. Danilov, thank you, Dr. Konovalov, for your insightful lecture and for sharing your unique experience. Augmented reality, the novel technology, and it can be applied in neurosurgeries. We can see it's interesting to note that augmented reality shares some ethical considerations with artificial intelligence. As in my opinion, the most important thing is that both technologies can be effective and safe only when they are guided by the experienced neurosurgeon. For example, if we make an error in model alignment, it will lead to mistake in surgical planning. However, when this technology is guided by experienced neurosurgeon, it can be incredibly beneficial for certain cases. And the same thing holds true for artificial intelligence. As Dr. Helmy said in previous lecture, both technologies, artificial intelligence or augmented reality, should be regarded as an additional tools and only in the hands of skilled practitioners. And there is one more intriguing topic, and this is the combination of augmented reality and artificial intelligence. Dr. Konovalov, how do you think will it be advantageous to integrate both technologies? For example, could the artificial intelligence segment and create the volumetric models of pathology automatically, and this volumetric model then will be uploaded in AR glasses?
Yeah, that's a great topic about the implementation, the AI in the augmented reality navigation and our and others neurosurgical fields and so on. Of course, yes, we already developing the auto segmentation with the AI modules, which can help to decrease the time of getting skills for segmentation, because the skill of segmentation, 3D segmentation for of DICOM data takes time of 3D modeling, how to align these, how to there are a lot of small steps which you can remember, and it takes time to get acquainted with the technology, start to develop your skills and so on. And of course, the AI probably will help us to average the skills for everyone. Like just you put the button and you get the segmented models of all the structures of the patient, and you just need to download it and put in the AR goggles. That's it. I think there are a lot of fields when we can implement the AI in AR navigational systems. As I said, the auto segmentation. Probably we may use the AI for alignment, like the AI will align the model without our intents. Like we just put the button which will ask the AI for align the model for this concrete like for this exact patient, and it will be done by like few seconds, and that's it. And the more accurate than all the human will do, like for manually. I mean, I think there are a lot of fields when we can use the AI.
Okay, thank you a lot for your answer.
Thank you, Dr. Konovalov. Thank you, Dr. Grebenov. And we have two questions, but before we go to questions, I just wanted to ask Professor Ioco-Kato and Professor Liu Bunseng if we can have some 5 or 10 more minutes to answer questions. May we take some?
Yes, please go ahead.
Thank you so
much.
much.
It's fine.
Thank you so much. So the first hand that was raised was by Dr. Phi-Huang.
Yes.
So please ask your question.
Thank you for the speech. Yes, I'm Dr. Hoy from the Physical Banda Hospital, Professor Kato Sensei. So thank you for a nice speak from Dr. Konovalov. And AI is so good for the enable to real-time and interactive 3D visualization. So I had a short question. And how can AR improve accuracies in neurosurgical planning, especially the deep brain injury or some the change the position? And do you recommend this? Thank you.
Yeah, thank you so much for question. There are few problems right now which we cannot solve. This is the brain shift, first of all, because it's really hard to predict how the brain will be shifted during the surgery. And I think the answer or like clue of this problem is to perform the intraoperative MRI and reconstruct the intraoperative MRI model for your exact period of surgery. Like if you need to check some positioning right now, you just perform the intraoperative MRI and create the new model, like intraoperatively right now. And this is the onlyest way right now to avoid the brain shift problem in AR and even the neuronavigational. So we perform the intraoperative MRI or CT scan for optical neuronavigation to solve the brain shift problem. And to improve the accuracy, we should develop more like accurate software tools for alignment. I think we will use the AI for getting our more accurate each step, like in the future. So of course, this AR neuronavigational system is not like super exact. Of course not. That's why we don't use it for deep brain simulation, for stereotactical biopsy, and some things like that. But for things which we should not be so accurate, like for STA, MCA bypass, and like to just align the model and understand where we should go, like how far we should go. It's really useful. I would say that.
Yes, thank you so much for answer.
Thank you. And the second hand was raised by Dr. Mohammed Helmi, but I don't see it now. But please, Dr. Helmi.
Yes. Yeah, so thank you so much, Dr. Konovalov, for this good presentation. So actually show us a very good technique on you talk about the pros of this using AR in the intraoperative settings and preoperative planning. And I think the pros of this is even more, as you said, in teaching. It enhances the trust between the patient and the doctor when you tell the patient everything about his disease in the preoperative talk discussion. And I think it also increases the physician confidence, as you said, when you have this kind of how to say, the surgical plan is already in your head before you're doing it. So it's so good. But the thing is, when you show the STA and part of the M4, I think it was M4 segment, right? Yes. So if I need to do bypass in the patient with myomed disease and I don't know, for the STA, I know it is on that place and there is no any pathological problems with this vessels. But in M4 branches, for patients with myomed diseases, even though there is the segment, the M4 cortical branch is present there, but we are not sure whether or not anatomically it or morphologically this is a suitable one. So before open, you decide that this gonna be the adequate recipient artery for my bypass. Because if I know this and I need to do the mini craniotomy, and after that I found this recipient is not good, so I need to expand my craniotomy. So this is my question. And it also gives the same example of, as Professor Dr. Gribinev asked about the informed consent of the patient. Whether or not I need to tell the patient, this is the result that it is given by the AR system, but we need to open and see, and probably I will change my craniotomy to find better recipient. Yeah.
Yeah, that's a great aspect which you noticed. We tried to AR navigation during the myomed disease, and there are a few moments. Of course, you are right that the myomed M4 segments really poorly visualized by the standard angiography methods. And that's why I would recommend to perform. We like experienced that problem, and we understood that we should perform the MRI 3D TOF, but the really high definitional examination for the myomed patients, which will help us to see the recipients, or like the M4 cortical M4 vessels, and then we can like segment them and show during the AR navigation. Also, we do not perform the small craniotomies for myomed patients. This is our like the rule. We don't use the small craniotomy for bypass in myomed disease patient, because we perform the like the complex revascularization, like direct and indirect for the severe myomed patients. And that's why we perform the larger craniotomies. Of course, everything is really individualized, and as you say, that the problem of changing your decisions on the information from the AR is the I would reverse this idea, because if you neurosurgeon, the responsibility of the surgery you perform on your shoulders, and all the tools, all the technologies, all the methods which you use, you're responsible for this usage. And all the information you get from these MRIs, optical neuronavigation, AR, like even the examination of the ophthalmologists, you get this information and you should perform your surgery in that way, in the proper way. but not in the way which recommended by any tools and so on. So you should have your own plan, and if the information is useful by AR navigation for you, you can use it. But if it's not useful, or if you kind of doubt this information, you should have the plan B for your surgery. You should now be so loyal for any tool that you can be mistaken in the surgical decision. Probably, maybe my idea was so complicated, but I think that you could understand that.
Yeah, it's very clear. Yes, actually, you emphasize the accountability. We have to have the accountability, like everything happen, whether you're using AR or any kind of AI tools, we should be accountable for everything that happens to the patient regarding to the decision making. The second thing, yes, you emphasize that the AI or any AI tools should be the how to say, the scalpel in our hands. It's not the one who hold the knife. So here is the point, because as you said, we should be accountable and very honest with ourselves and with the patient. But I think it also gives us the necessity of having this kind of as I just said, ethical committee in each department, because probably you are very responsible person. If something wrong happen, you're gonna be more honest with your patient and tell them and blah, 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 blah. This is not the case in each institution. So with the advances and the progress of using these AI tools, do you think the presence of such committee who can control the use, or not control, just govern the physicians who are using AI tools are necessary to be in the department?
Yeah, of course, I absolutely agree with that. With every technology we get, we should get the specialists who will check the like the accuracy, the ethics, the safety of this technology, and so on. Because it's not the problem of AI or AR navigation. If you do mistake during the surgery, it's not the mistake of the tool, it's your mistake. So that's why all the surgeons from all over the world has the plenty of tools. Like, if we doubt the accuracy of optical navigation, we should know exactly the anatomy. So anatomy never lies, as we know. And if you a neurosurgeon and you don't know the anatomy, you don't even enter the operative room. And if you're the surgeon who knows anatomy, you don't need the optical navigation, but you can use it to get some more information, which may increase your expertise in your surgery. So the base that you know the 100% your responsibility and your skills, and then you can use the additional tools. But I understand what you mean, that nowadays the younger neurosurgeon really loyal on the optical navigation, and it mistakes a lot of times. Yeah, that's a big problem.
Thank you so much.
Thank you so much, dear colleagues. Today was great webinar, in my opinion. Very nice lectures, very nice discussion. And as with any technology, the success of technology is related to a proper point that it can be applied to. And I hope that our further efforts, our research will provide more robustness, and we will support our movement towards that very good point. So we need to close our webinar. But before, if I'm allowed, I just wanted to announce a very interesting research that is conducted by Dr. Stats, just literally 1 minute. So Dr. Stats is conducting very interesting study, a survey among neurosurgeons and physicians from related specialties and he's trying to understand doctors' attitude toward synthetic medical images generated by AI. So there is a link to a questionnaire, and Dr. Statges would like to distribute it among ACNS members, and we kindly ask Professor Kato if that is possible. We can share this link with the ACNS community so that everyone can participate in that.
Yeah, please. Yeah, of course, please.
Yeah, thank you so much, Professor Kato. May I ask you to say some closing remarks?
Oh, so I think that we had a great lecture from two giant of the AI researcher, and as one of the ordinary neurosurgeon, I think it's AI is great support for our maybe the planning and also the avoid complication or maybe surgical tool and also the intraoperative phase and also the maybe I think personalized with the treatment and rehabilitation so on. And so it's very, very useful. So thank you very much for your great lecture.
Thank you so much.
Appreciate it. Thanks.
Thank you so much. So we can probably finish our second webinar, and we hope to have a third soon. Thank you so much.
Yes.